as I said, I'm running with the mobile signals, right? So topic is the bradycardia and investigation and management. So to understand bradycardia, basically we should have some understanding about the conduction system of the heart. When you have some idea about the conduction system, it is easy to understand about the bradycardia. So just to remind you, this is the basic structure of conduction system of the heart. So impulses start from the SA node and it travels through the atrial muscles and it comes to the atrioventricular node. Then from there it comes to the bundle of fish, and then it will be divided into left bundle and right bundle branches, and then left bundle branch will be further divided into posterior and anterior fascicle, and then these fibers further subdivided as Purkinje fibers, and they will supply the muscles of the heart. So that is how like electrical signals originated from the sinoatrial node will come down to the cardiac muscles. So natural pacemaker of the heart is sinoatrial node. So if conduction system is working well, sinoatrial node is the structure which control the heart rate and rhythm. If there's any problem in the SA node, sometimes there may be other areas of the heart which can take over the function of SA node. So then they will give rise to various abnormal rhythms like atrial rhythms, ventricular rhythms, junction rhythms, nodal rhythms, atrial fibrillation, flutter. All those arrhythmias comes when the SA node is not functioning properly. Or the other areas of the heart start behaving aggressively or without much control. So this is the basic structure of the conduction system. So when you say bradycardia, what do you understand? What is bradycardia? Anybody?
Heart rate less than 60 beats per minute.
Yeah. It's the basic classification of the the classification is the bradycardia means heart rate less than 60, and tachycardia means more than
120.
Is it
100?
100?
100.
Yeah. More than 100 is tachycardia, less than 60 is bradycardia. That is how we define bradycardia and tachycardia. So sometimes with bradycardia we call it as bradyarrhythmia, and tachycardia is tachyarrhythmia, because all these are rhythm problems in the heart. So bradycardia, sometimes bradyarrhythmia means the almost same, right? Tachycardia, tachyarrhythmia, most of the time, like meaning wise, it's similar, right? How can we classify bradycardia? What are the ways and means of classifying bradycardia? Is there anybody?
Bradycardia. Originates. Where it originates?
Yeah, basically depending on the structure, where is the problem? That is how we classify bradycardia, like depending on the where is the disease, right? So based on that classification, bradycardia can be divided as sinus node dysfunction, problem in the sinus node, right? Then AV nodal dysfunction, right? When you say sinus node dysfunction, there are other subclassification of sinus node dysfunction. Earlier, there was some classification like type 1, type 2, type 3. That is, type 1 was, if there's a bradycardia only, it is type 1. And bradycardia with pauses is type 2. And bradycardia and tachycardia, type 3. So that classification is no longer in use, but still sometimes you might see six sinus syndrome type 1, type 2, type 3, right? It's basically all the classification. We are not using that much now. So what we now say is it's sinus node dysfunction. So it could be type 1, type 2, type 3, or sometimes chronotropic incompetence also comes under sinus node dysfunction, right? So all these problems are sinus node dysfunction. Then AV nodal dysfunction, it could be first degree, second degree, or third degree heart blocks. All those things are heart blocks, right? Then it could be other conduction tissue abnormalities. Mainly these problems are due to problems in the SA node or AV, but sometimes it could be the problems in the other areas of the conduction system. Any example, anybody?
Sir, it was not clear. We couldn't hear.
You can answer. I don't mind giving a wrong answer. Give me a second.
Sir,
Sorry.
internet connection is poor, sir. Sometimes we can't hear.
Sorry. Just give me. Now is it clear?
Yes, now it's okay.
Yes, now.
Yeah, right. Sorry, because as I said, it's running with the mobile signal, so sometimes it drops, right? So, okay, so classification, you were clear, right?
Yes, sir.
Right. So, what I was asking is there like any examples for any other conduction tissue abnormalities? You are aware of anything? Anybody?
So bundle branch blocks. Bundle branch.
Yeah, bundle branch blocks also, yeah, it comes under other conduction tissue abnormalities. So there are examples of other conduction tissue abnormalities as well. It could be bundle branch blocks, then it could be fascicular block, anterior fascicle, posterior fascicle. Like that, there are other parts of the conduction tissue system could be disease, and it can give rise to bradycardia. So those are the main like categories. When we categorize according to the disease process, these are the categories we can come across, right? Then right. So what is this? Can you see the ECG?
Yes, sir. The
Yeah. What
sinus
is there?
arrest. There's a sinus arrest, sir.
Sinus?
Arrest.
Sinus arrest. So anybody else? Any other problem? Any other answers?
Sir. Tachybrady syndrome, sir.
Tachybrady. There's no tachy part. Brady is there.
Sinus arrhythmia.
Sinus pause.
Yeah.
Sinus pause.
Sinus pause.
So, yeah, it's a, you can see if you, can you see the cursor?
Yes.
Yeah, you can see this part in the middle part of the rhythm strip, that is lower bottom strip. If you can concentrate on that, you can see middle part, there's a sinus rhythm, regular heart rate is around 75, right?
Yes.
But both sides, you can see some bradycardic episode, sinus, but there's a pause, and then start again with the sinus beat, right? So those are called sinus pauses. These are feature of sinus node dysfunction, right? So these are actually, this is exit block. I'm not going into details about these bradycardia mechanisms and other things because I don't think you need to know all those things. But this is some call this is sinus pause, some say sinus arrest, some say it's exit block. Depending, various names are used, right? All those things are still. All those you like use those terms like a similar meaning. There are slight differences in each term, but when you hear those things, it's almost like you will get the same feeling, like it's a sinus pause or sinus arrest, sinus exit block, all those things. You will get the similar idea, right? So this is a sinus node disease. Sinus node, time to time it is having problems, right? What is this?
Complete chart.
Hmm?
Complete chart.
Yeah, it's a complete heart block. You can see if you see the QRS or RR interval, you can see there's a bradycardia. Then you can see the P waves are there are frequent P waves than the QRS complexes, and there's no relationship between P waves and QRS complexes. So this is a complete heart block, right? If you have any questions, you can ask, right? If you can't understand or if you have any problems, you can just ask. You can explain, right? Right. What is this? There are few abnormalities in this ECG.
So trifascicular block, sir.
Sorry.
Right bundle branch block, first
Okay.
degree heart block, and the right
Right.
axis patient is
Yeah.
a trifascicular block.
Yeah, it's good. Yeah, it's a trifascicular block. You can see there are several abnormalities. One is you can see a first degree. Sorry.
Right bundle branch. No.
Yeah. Yeah, you can see a right bundle branch block here. If you see V1, V2, you can see RSR pattern. So it's a right bundle branch block is there. Then you can, it's not very clear, but you can see PR interval is prolonged than 200 milliseconds, so more than 5 small spares, right? Not very clear in the ECG, but it's prolonged. Then there you can see lead 2 is negative, so that means there's a left axis deviation, right? So when you take all three together, we call it as trifascicular block. People with trifascicular block can go into trifascicular block means what has happened? What is the meaning?
Can go into complete heart block.
Yeah, because that means trifascicular block means there's a like expensive conduction tissue problems. Because right bundle branch block means right bundle branch is not working properly, right? First degree heart block means AV node is not working properly. Then left axis deviation means it is left anterior hemiblock. That means the anterior fascicle of the left bundle branch is not working properly. So you can see there's an extensive conduction tissue problem. These people can go into complete heart block at any time. So it is a, if you see this type of ECG, you have to be careful. If somebody comes with this type of ECG and complain of loss of consciousness, syncope, you should strongly suspect complete heart block, right? Intermittent complete heart block. Right. So, okay, then this is the classification. So when you, I think all you are doing, like most of you are in CCUs or cardiology ward or cardiology unit. So how can they present? Somebody with bradycardia, what are the presentations? How can they present?
Pre-syncope, syncope, shortness of breath.
Yeah, one is pre-syncope and syncope. It's a very common presentation. That's the like common as well as we have to take it serious. Syncope and syncope, right? Then what else?
Faintishness, loss of consciousness.
Yeah, they will use different terms, right, to explain this thing. Syncope and pre-syncope. They won't come and say you I have pre-syncope or syncope. They will use different terms depending on your education level and the understanding of the language and maybe sometimes the ethnicity, sometimes maybe due to the various areas of the country, they use different language to express the same thing. So you will you will come across different terms in different areas, different people use, right? Some might say it's faintishness, some say it's a dizziness, some might say it's a vertigo, imbalance. Then, like that, there will be different terms being used to describe this pre-syncope and syncope. So you should be able to take the history properly and identify whether it is a pre-syncope or syncope, because vertigo means different issue. You say somebody comes and say Karakavilla, that is, you have to understand. Some are telling Karakavilla to same thing as Sihinathilina, right? They can somehow use karma. So you have to be careful what they are describing. So vertigo, you have to be careful because sometimes they will come and say Karakavilla. Another one is exertional shortness of breath. Again, very common presentation. Exertional shortness of breath. Then generalized weakness, especially in elderly people, they say Angata Pathar Panane. That is their main presentation. Istaravagi Panane, Kammeli, Vedak Karanne, right? Generalized weakness. That is another complaint. Then palpitation. Is it common with bradycardia, palpitation?
Yes.
Why?
Bradycardia can feel as palpitation.
Yeah, sometimes it happens due to two reasons. One is some people say palpitations because when your heart rate is really slow, they will feel the beat, right? Then they say something, then they will say palpitation. Sometimes what happens is in tachycardia syndrome, especially, they will feel palpitations, tachypart, but not the bradycardia part, that part. But what will happen is they will say, they will feel the palpitation, then they will, after palpitation, what happens usually, there will be a pause. During that time, they will feel faintish. So what they describe is palpitation and then faintishness. So most of the time what happens is when somebody come up with that complaint, if you don't like investigate that patient and if you like not listening to the history properly, sometimes what do you do? This is the common scenario, right? What are you going to do? Most of the time, you will start, they will start anti-arrhythmic rate limiting drugs to control the palpitation. That is what happens. So then they will start, like, they will be started on these anti-arrhythmic drugs, like rate limiting drugs, beta blockers, calcium channel blockers. What will happen?
Further deterioration.
Patient will be getting more symptoms. They will become
Worse.
more symptomatic. So tachycardia syndrome is a very difficult, sometimes very difficult scenario to diagnose. So in case to diagnose, because of this reason, because they come and say palpitation, they won't tell much about the dizziness and the pre-syncope part. They will say palpitation. So what will happen is they will be started on these rate limiting and antiarrhythmic drugs, and symptoms become more and more bad. So that is what happens. So that you must remember. Sometimes bradycardia can present as palpitation, right? Not very common, but can present. Other scenario? Other than incidental, because of the medical checkup, sometimes especially this army forces people, they will have regular checkups. So they will, during medical checkups, they will get, sometimes when they take ECGs, they found to have bradycardia and then referred, right? Those are incidental patients. They are not symptomatic, but incidental finding during medical checkup. Sometimes when their patients are like waiting for some surgery, pre-op assessment. Sometimes they undergo ECGs. It will be found that they are bradycardic like that. It could be incidental. Usually patients are asymptomatic, right? So all those way they can present could be symptomatic or asymptomatic, but those are the common presentations. There are rare presentations as well, but those are the common presentations, right? Then how to manage? Right. Management depends on your clinical assessment, right? You have to decide whether this patient is hemodynamically stable or not. That is the most important decision you have to make at any point. You may be in the OPD, you may be in the ETU, you may be in the CCU, you may be in the cardiology ward, you may be in the clinic. At any place. If somebody comes with a bradycardia about presentation, you have to decide whether this patient is stable or not. That is the most important decision, because your management and investigation depends on that decision, right? So how do you decide that patient is unstable? What are the parameters? So what are the clinical signs, symptoms, and what are the other things which will tell you that patient is hemodynamically unstable?
Very low blood pressure, severe bradycardia,
Blood pressure.
patient
Bradycardia is
symptom,
anyway there, so very systolic blood pressure less than 90, right? Low blood pressure. Then what else?
patient is confused,
Yeah,
Unconscious.
confusion or impaired level of consciousness. That is a strong sign of instability. That is, brain is not perfused properly. So confusion, low GS, GCS, or this impaired level of consciousness, altered level of consciousness, all are in the background of bradycardia, signs of instability, right? What else?
bradycardia induced tachy,
Yeah, sometimes it can happen, but it's not it per se. We can't say it's will indicate instability. What are the other main parameters?
Ongoing chest pain, features of LVF.
Sometimes the bradycardia can lead to LVF. If LVF is there, yes. But chest pain is not very common with bradycardia. They will say some typical chest discomfort, chest pain like ischemic chest pains are not very common. Sometimes ischemia can happen, but not very common. They might say chest discomfort, right? But it is not a feature of instability. What are the features of instability? The hemodynamic instability.
Signs of end-organ damage,
Like what?
acute kidney injury, AKI, ongoing AKI.
AKI, yes, but like point of examination, you
Lung signs will be there.
Reduced urine output.
yeah, those are like late presentations, right? Because if somebody comes to you to clinic or CCU, to say take some time to assess whether the urine output is less or not. But what are the things you can assess immediately?
Cold clammy peripheries.
Yeah, all clammy peripheries, if it is there, yes, that is a peripheral perfusion is poor. You can get that. Sometimes in the background of bradycardia, we can take it as a signs of instability. What are the main things? Blood pressure,
Breakdown.
conscious level, and
Lung
Less
sign.
than 40.
lung signs. Like
Pulmonary edema.
pulmonary edema, yes, if your heart failure is there, you can see. But what are the main things? If you are in the CCU, what are the things you are going to monitor?
Low SpO2.
Saturation.
Saturation, yes. Oxygen saturation, if it is less than 94 in room air, that is a feature of instability. Then the respiratory rate, tachypnea. Patient is tachypneic, breathing short of breath. That means he is not stable, right? So those are the main features, like low BP, low saturation, tachypnea, and in,
Impaired conscious.
Conscious level, and sometimes impaired peripheral circulation. Those are the main parameters you can assess. If those things are there, you have to be careful because the patient is at bradycardia, so he is hemodynamically compromised due to bradycardia. So you don't have much time, you have to act quickly, right? This is a sort of an emergency. So you have to do something quickly, otherwise patient might go into problem, right? So in this situation, you have to be careful. If those things are not there, that means although patient is bradycardic, he is not hemodynamically unstable. So you have some time, you can decide on your investigation, you can do investigation and you can decide what to do. But if features of hemodynamic compromise is there, you have to act fast. These are emergencies, right? Then how to manage in acute situation? What are you going to do, right? Okay, so most of you are in CCUs now. So right, the patient comes to ward, suddenly patient collapsed and then found to be bradycardic, severe bradycardia, heart rate is around 30. Then he is admitted to the CCU, ICCU, whatever the emergency care unit. So what are you going to do now? You attach him to the monitor, you see heart rate is going around 30 and saturation is low, blood pressure is low, patient is not very conscious. What are you going to do? ABCD management, yes, right? It is common for any patient, so I'm not going to discuss about ABCD management. I'm discuss about the things are like directly related to the bradycardia, how to manage bradycardia. But when somebody comes with unstable position, you have to do the ABCD management. So I'm not discussing that. But yeah, so how are we going to manage this patient now?
Immediately we can give IV atropine boluses till the
Right, yeah. Immediately you can use some drugs to increase the
Heart rate.
heart rate. What are the drugs you can use? Atropine is one. What else?
Isoprenyline.
Isoprenyline.
Isotretinoin. Then
Noradrenaline.
noradrenaline. Adrenaline. Noradrenaline. Then
Salbutamol, oral salbutamol.
salbutamol. Okay. So those are the mainly used drugs. Sometimes dopamine, dobutamine, all those drugs are used, but commonly used drugs are atropine, isoprenyline, salbutamol, and adrenaline. Those are the commonly used drugs in bradycardia. Most of the other drugs which has inotropic and chronotropic effects can be used, but those are the common drugs. Right. The problem with the drug, what is the problem with the drugs? Problem is drug effect is usually
Slow.
short lasting.
Short lasting.
Right? When you give drugs initially they will respond, but after some time this response is less. You can see sometimes when you give initially atropine, they will respond very well, but after some time when you give repeated doses or when you give infusions, effect is less. So this will happen with the drugs. So drugs is not a permanent solution for the bradycardia. Then what is the permanent solution? Permanent in the sense, what is the reliable solution for bradycardia? Symptomatic bradycardia.
Pacing. Pacing.
You have to go for
Pace.
temporary pacemaker, right? So if somebody comes with bradycardia and if you think hemodynamic unstable, your aim is to arrange temporary pacing. That is the reliable mode of management. But till you arrange temporary pacing, you can't allow patient to die in between. So to bridge that gap, you will use above mentioned drugs. To keep heart rate little bit up, we use those drugs till we arrange something reliable, right? So when you take the temporary pacemakers, there are two types, external and transvenous. Do you know about those things? External, have you heard? Have you used? You are in the CC, you must know, I think, right? Okay, there are two ways, external and transvenous. Then, what is the next step? Once you stabilize patient with a temporary pacemaker, it could be external or transvenous. Then you have some time because you have some reliable way of maintaining heart rate, right? Once you are stabilized with the temporary pacemaker, then you have to look for any reversible cause. Whether there's any, you have to check for, you have to look for whether there's any reversible causes. If there's any reversible, I will come to the causes, but if you have a reversible causes, you have to treat the cause, whatever the treatable cause. When you treat that cause, then patient should be taken off from the temporary pacing, because once the underlying problem is treated, patient should be better. Then we can take the temporary pacemaker out, right? In some situations, there are no treatable causes, especially in degenerative problems, right? Most of the time, people with the old age, they will get degenerative problems in the conduction system, maybe SA node, AV node, or other conduction tissues. So if it is due to degenerative conduction tissue problem, it can't be treated. At the same time, there are other reasons sometimes which can't be treated. For instance, ischemia is usually treatable, reversible most of the time. But sometimes, can you treat all the ischemias? No. Sometimes we can't, because sometimes the very chronic ischemia, sometimes severe triple vessel disease, sometimes a lot of CABG done, elderly, we can't do any intervention. So all those situations, yes, we know this ischemia, but we can't treat. In that case, what happens? It becomes an irreversible cause. In that case, we have to treat the bradycardia, whatever the possible thing, right? So sometimes reversible things may become irreversible depending on the circumstances also, right? Then if the cause is irreversible or untreatable, then we have to go for permanent pacemaker, because temporary pacemaker we can't keep for a longer period, right? It has other adverse effects, so we have to take the TPM out as early as possible. So then, if the cause is irreversible or untreatable, then you have to go for a permanent pacemaker. This is the outline of management of acute unstable bradycardia. Our aim is to go for a temporary pacemaker till such time we use drugs to bridge the gap. Then we see whether there's any reversible or treatable cause. If there's any, we treat that. Then patient should be better. Then we can take off the TPM. If it is not, if it is cause is irreversible or untreatable, then we have to go for a permanent pacemaker, right? That is our usual outline of acute management of unstable bradycardia. What are the reversible causes you are aware of? Examples? Can anybody tell a few examples?
Poison.
Hypokalemia.
Poison.
Hypothyroidism.
Yeah, anaerobic poisoning is one.
Electrolyte
Various
imbalances.
degree of AV blocks, heart blocks, right? Then hypothyroidism is another.
Hypothyroidism.
Yeah, I told you about the ischemia, especially acute
Electrolyte
myocardial
imbalance.
infarction. Electrolyte imbalances. What is the commonest electrolyte problem?
Hypokalemia.
Hyperkalemia. Any other causes?
Drugs on beta
Drugs,
blockers. Beta blockers.
Yeah, beta blockers and all rate limiting and antiarrhythmic drugs can lead to bradycardia, maybe as a side effect or as a overdose, right? Sometimes it could be a side effect, or sometimes it could be a overdose. So these are the causes, common reversible causes, right? Other one is uremia or chronic renal failure, and uremia sometimes can lead to various conduction tissue problems, bradycardia, sinus, so heart blocks and other things. Sometimes it is treated, can be treated, sometimes we can't. Because sometimes there are people with chronic, who are not on dialysis, they are in a uremia. Then we can't treat that condition, right? So in that case, we might have to go for a pacemaker, permanent, right? Sometimes we can do the dialysis, we can do regular dialysis, or we can do kidney transplant and other things, so we can treat. So this can happen, right? Electrolyte imbalances we discuss, especially hyperkalemia, then metabolic abnormalities, mainly hypothyroidism. Drugs we discussed this also, isoprene, atropine, adrenaline, and targeting. So, do you have any idea about the external pacing? Have you used external pacing, or do you use external pacing as a emergency treatment method?
Yes.
Yes,
Yes
sir.
or no?
Yes, sir.
Which hospital? Go ahead.
Teaching
Karapiti,
hospital,
sir.
Karapiti.
Karapiti, right. Good. Any other hospitals?
Candy.
Candy, yes. Right, yes. External pacing is it there in your CCUs?
Yes, sir.
Yes, most of the CCUs have external pacing, but most of you are not aware that it is available, right? Some are asking, yes, external pacing are there, where is the machine? Sometimes I say it's in your ward or somewhere. They go and say, no, nothing is there, no external pacing machine. I asked from the nurse or sister, there's nothing like that. So where is the external pacer? Is it separate machine or with something else?
It's in the monitor, sir.
Defibrillator machine.
It's in the
The defibrillator.
Defibrillator.
It's an additional feature or inbuilt in the defibrillator machine. We don't have external pacers as separate machines yet. We basically have it in. So, what are the advantages and disadvantages of external pacing? People who are using,
Non-invasive.
what are the problems?
Non-invasive.
It's a non-invasive, yes. Then what else? Yeah, when you take advantages, there are several. One is it's freely available, right? Almost all new defibrillator machines have external pacing facilities. So most of the places, although we don't know, it is available. If you don't know, if you know how to use, you can use, right? There's an advantage. Availability is more because then it's a non-invasive. Like we don't have to do anything invasively. We have just need to place the defib pads, right? Then technique is easy. We don't need to have very much in-depth knowledge, or we don't need to have a lot of experience, because if you know how to put that, you can use that. This is not difficult, right? So those are the advantages. What are the disadvantages?
Patient discomfort.
Yeah, because it will pace the heart through the
Muscles.
chest wall. Electrical impulses going through the chest wall to the heart, so patient will get chest discomfort, pain, and muscle twitching and other problems. So it is uncomfortable or painful to the patient. Other thing is capture is not reliable. Sometimes we can miscapture, right? So not reliable capture is not very reliable. Those are the disadvantages of
External
main
pacing.
disadvantage of external pacing, right? So have you seen this? So if you are not aware of this temporary pacing, external pacing, you go and check your this defibrillator machine. Most of the time, there are several modules are there. If you see, there's some area there will be pacing
Yes.
unit, some area dedicated for pacing.
Yes.
You can see the rate, mode, all those things are there. You can go and check, right? And you should know how to use that. So very useful. Sometimes we can't transfer the patient, or if you can't maintain the heart rate with drugs, if you don't have facility. Sorry for that, because it all reset. Right? So we discuss about external pacing is usually done with this defib pad. It will be pasted on the patient's chest like we do with when we are doing like cardioversion or DC shock. We have to paste the these pads on the chest, and then we do the this thing. You should have some practical knowledge about that, right? And transvenous pacing, how we do is we put a wire through the femoral vein to the right ventricle, and then we'll do the pacing. So I think you have a session on temporary pacing. So Dr. Susita will do it, maybe the next lecture, right? So he will explain you and he will teach you how to do that. So I'm not going to touch that part. So I will. What are the advantages of transvenous pacing?
Reliable.
It's a very reliable way of pacing. When you compare the external and transvenous is more reliable than the external pacing. That is the main advantage. What are the disadvantages?
Invasive.
Invasive.
It's invasive, so a lot of complications can happen. Infection and the bleeding, vascular damage, perforation of the heart, all those things can happen, right? Okay, invasive. Then what else?
Need to check
Then you
follow up.
you should know how to. Everybody can't put the
If it's a
transvenous pacemaker. Not like external pacing. You should have some skill to do that. Everybody can't do that. You should have some experience to do that. That means you should have some skill. At the same time, we can't put temporary pacemakers each and every hospital. There should be a thoracoscopic facilities, so the cath lab should be there to put the temporary transvenous pacemakers. So sometimes we can put blindly, but it is not advisable. A lot of complications. So it is you should have those facilities. Most of the centers they don't have transvenous facilities. So most of the centers which has teaching hospitals and some of the centers which have cath labs will have those facilities. Most of the places you don't have. You have transferred to the nearby hospital to get the TPM done. So in these situations, it's better to know about the external pacing. Disadvantage, those are the main disadvantages. This is a temporary pacemaker wire. You can see these are the equipment. I think, as I said, Dr. Susita will go through all those things, and he will teach you how to manage and how to put these patients, right? Then this is the management of unstable patient. Any questions or anything you want to clarify? If anybody has any questions, you can ask, right? Right. Then you assess the patient and you think that patient is stable, right? Hemodynamically stable, not very unstable. In that case, you don't have to rush for the management, right? Then you can take the proper history, you can think about the process, and then you can do the investigation. ECG is mandatory for any patients with suspected bradycardia or any arrhythmia. So ECG is must. It's a basic investigation. That's why I did mention it here. The ECG is must for any patient, but other investigation we decide based on our suspicion, right? What are the investigations we can use, or we can use to further evaluation of bradycardia?
Yes. Holter.
Yeah, Holter monitor, right? Sometimes when you patient comes and say, I have on and off faintishness or pre-syncope, but when you see the ECG, nothing is there. You suspect this is a cardiac related pre-syncope. In that case, you might do a Holter study to see whether there's any bradycardic episodes. So Holter could be 24 hours, 48 hours, 72 hours, or maybe 4 days, 5 days, depending on the capacity of the machine. But we generally do 24-hour, 48-hour Holter, right? We don't go beyond that, depending on our resources and the capacity of the machine. We are not going for longer period. Any other monitoring facilities you are aware of? You
Telemetry.
know any?
Telemetry.
What's that? Sorry, I could get you.
It's cardiac telemetries.
Telemetry, okay. Any other machines? Any other devices?
Recorder, loop
other
recorders.
Loop recorders are there, yes. Loop recorders are there. And there are machines like cardio, memo. Those are longer period, maybe a few weeks. Loop recorders can record up to 2 years. And then newer mobile phones and sometimes new mobile apps are there. If you feel faintish, sometimes you can take a recording of your heart rate for about 30 seconds or 1 minute using that apps or mobile phones, right? Those things are there. These things are very useful because sometimes it is like occasional syndrome, rare symptoms. Sometimes patients say palpitations once in a month or dizzy feeling once in a month. So very difficult to catch with a Holter. If you have a mobile phone, if they have a mobile phone or mobile app which can record for about 30 seconds or 1 minute, when they have the symptoms, they can get a rhythm strip like recording. So it will be helpful. Sometimes we can detect bradycardia or tachycardia, various things, right? So those things are there now, newer machines and devices. Then exercise ECG. Why exercise ECG? What is the importance of exercise ECG?
To assess the chronotropic competence.
Yeah, mainly to assess the chronotropic competence. When you physically exert yourself as a compensatory method, heart rate and blood pressure should go up. But if your sinus node is not well, not functioning well, sometimes your heart rate won't go up. Then patient can't exert. So when you put them into the exercise machine, they can't do much because their heart rate is not going up. So they will feel tired very easily. That is one. Sometimes with this conduction issue problem, sometimes they will develop heart blocks when they exert. Sometimes because they give heart, other conduction tissue problems are there. They when they exert, they will develop heart blocks because their heart tissues can't conduct fast. Then they will develop heart blocks. They will become obvious, right? So that is the importance of exercise ECG. Then other investigations like TSH, serum electrolyte, creatinine, depending on your suspicion. We should not do all those investigation for each and every patient. Depending on your suspicion, you can select what are the investigations. If you suspect hypothyroidism, maybe by looking at the patient, because sometimes hypothyroid patients are by looking at them and when you talk to them, you can understand this patient is hypothyroid, right? This is you can go for the TSH. Like that, you can select other investigation depending on your suspicion. Then echocardiogram is not mandatory for each and every patient. But we usually do a routine investigation for bradycardia also. But selected patient, depending on the suspicion, sometimes if we need to assess the LV function and other things, we can do a echocardiogram as well. The special investigation is a Holter study, most of the bradycardic patients, right? Right. Any questions so far? That is basically management and investigations of bradycardia, right? If you have any questions, you can ask. Now, I think I have taken about 1 hour and 5-10 minutes. Is it 1 hour, 1.5 hours?
As long as it takes
1 hour is better, no? Right. Into time, I will go through few cases, right? Lecture must be, but you go through these cases because it will be. I'll go through 4 cases and then I'll stop, right? Do you have any questions? Or shall I go to the cases?
Sir, excuse me. Hello?
Sorry? Yeah.
Hello?
Hello, yeah. I can hear you.
Sir, in athletics and the heavy manual laborer with asymptomatic bradycardia, do we need to do the Holter and these kind of investigations?
Sorry, I couldn't get your first part. I can hear that.
Sir, patients like
Can you repeat the question? Sorry.
asymptomatic bradycardia patients, like athletics and the heavy manual workers, do we need to do these investigations?
It is like that. It's depending on the situation, right? For instances, you see somebody, you see it's a trained athlete who is doing long distance run or something like that. Somebody with that caliber comes with a incidentally found to have bradycardia of around 50 or 48, 50, 52 or something like that in ECG. Right? When you take the history, nothing is there. So in this situation, you can basically reassure them that this due to this, don't worry. But sometimes it is for a medical, right? Sometimes we have to do the investigations and tell them, see, this is a normal for him. Nothing to do, because otherwise they might not take our word if we say, no problem, right? Sometimes we might have to take a Holter like that. Sometimes it's very difficult to convince anesthetists to give anesthesia if we don't do the investigation. They keep on asking same questions. This patient is bradycardic. Then we have to do the Holter, echo, and all those things to convince them. Like that, it depends on the situation, right? At the same time, if the bradycardia is very severe, you say if somebody comes with a heart rate of around 30, 35, 36 with a asymptomatic, you might have to do the investigations and see what is the underlying situation, because sometimes what will happen is always it is better to do baseline investigation, in my personal opinion, because if you see a incidental finding, no, because then after some time you can compare. At the same time, you can reassure the patient. You can reassure whatever their requirement can be like tackled very well when you do the basic investigation. As I said, don't do all the blood investigation like electrolyte, creatinine, full blood count, D-dimers, troponin, all those investigations don't do. Just basic things. Maybe one Holter might be enough, right? Okay, shall we move to the cases? Only 4 cases, right?
Okay.
Right. This is the case 1. We have discussed most of the things, but you can come up with whatever the answers you have. 82-year-old male presented to ET with loss of consciousness. He is on treatment for hypertension and ischemic heart disease. Patient is confused. Pulse rate is 28 beats per minute. Blood pressure is 80/50. Oxygen saturation is 84. ECG, complete heart block. No acute ischemic changes. How we are going to manage this patient? Is it an emergency or not?
Emergency.
Yes.
Medical
Yes.
emergency. We have to act. Otherwise, this patient is going to die. So it's an emergency. So basically, we discuss this scenario, right? We discuss we have to start with the drugs. Then we have to go for a temporary pacemaker. And then we have to assess, or we have to check whether there's some reversible causes. If there's some reversible causes, we can treat. But if there's not, we have to go for permanent pacemaker. By going through the history, what do you think? Does he need a pacemaker or not? Permanent pacemaker or not?
Yes.
Yes, most of the time, yes, because there's no any ischemic changes with the heart rate 28. The other reasons are very unlikely unless he has some hyperkalemia of potassium of 7 or something like that, which can lead to heart block. Most of the time, he might need a permanent pacemaker, right? This is a case 2. 65-year-old female treated again with on and off faintishness for 4 weeks duration. No loss of is on treatment for diabetes mellitus and hypothyroidism and dyslipidemia. Pulse rate is 60, blood pressure is 130/80, saturation is normal. ECG sinus rhythm, ST3AV block, right branch block is there. What you have to do? Is it an emergency or not?
Not emergency.
Not an emergency, right? Although patient has symptoms like faintishness, at the time of the presentation, she doesn't need. He doesn't have any hemodynamic. In these situations, those don't start all those adrenaline, salbutamol, atropine, isoprene, and try to put patients on TPA, right? Because these patients are, although they are time to time symptoms, these are at present they are stable. In these situations, don't try whatever we are trying to do. What you're doing with unstable patient, right? You have to understand the situation, because what we have seen, sometimes patients are transferred for temporary pacemakers from other hospital. Patient is very okay, heart rate is 60, patient is when we try to put the temporary pacemaker, when somebody who is not experienced enough, they have transferred this patient. They are trying to. Patient is jumping out of the bed and running around. What they are going to do to me, right? So they are fit enough, no problem, right? They are okay. In these situations, don't like do any unnecessary things. You have to think rationally. Okay, now patient is stable. Of course, yes, you have to observe this patient for maybe ECG and basic things you have to do. Then this is not an emergency. You have to understand that, right? Then what you are going to do this? What you are going to admit this patient, or you are going to discharge this patient?
Investigate with PSH.
That's what I'm asking. Are you going to admit or are you going to discharge? What do you think?
Admit and investigate, sir.
Yeah. In this situation, I think because patient has come to the ETU, so that means she may be having a frequent symptoms, right? We had several episodes during last thing, so it's I think better to admit and do at least whatever the ECG and whatever the basic investigations and see. Observe for about 24 hours and see. You can put them into a cardiac monitor and see whether there's anything you can detect. If you can't arrange a inward Holter, right? Then you can subsequently do whatever the investigations depending on your suspicion, right? Right. You can see in the ECG also there are a lot of abnormalities. Okay, because there's a pulse rate is 60, so sinus node is not functioning properly. First degree AV block is there, so AV node is not functioning properly, right bundle branch. So conduction evidence of conduction tissue problem is there. So you have to suspect this patient may be having some sort of a chronic problem, right? Okay. Okay. 58-year-old farmer presented to OPD with exertion and shortness of breath for 3 months duration. On treatment, he is on treatment for diabetes mellitus. Pulse rate is 48 beats per minute. Blood pressure is 140 by 90. Saturation is normal. ECG sinus bradycardia. What do you think? Is it an emergency or not?
It's an emergency.
It's not an emergency. He is stable, right? Are you going to admit this patient or not?
Yes.
No need to admit. Can investigate as outpatients, sir.
Yeah, I think it can be investigated as outpatient because main symptom is exertion or shortness of breath has been there for 3 months, and at rest patient is okay, and other hemodynamics are stable apart from pulse rate of 48. It's not too bad. Bradycardia, sinus bradycardia. There's no any other evidence of significant conduction tissue problems with ECG. So in that case, no need to admit, right? No need to admit this patient. So you can plan out the investigation and you can send the patient home. Then you can review with the investigation, right? No need to admit. Forty-year-old army soldier referred to clinic due to incidental finding of bradycardia in regular medical checkup. Otherwise, healthy. Pulse rate is 48, blood pressure is 130/80, saturation is normal, sinus bradycardia. What do you think? Is it an emergency or not?
No.
It's not an emergency. As I said, this is a very common scenario. Right? Causes people, a lot of people are referred due to same problem, right? Do we have to investigate this patient?
No.
Do you have to investigate this patient or not? We discussed this same questions earlier. I gave the answer. What should we do?
Might have to.
Reassure.
Yeah,
Might
if patient is perfectly okay, yes, we can reassure and we can send him home. But sometimes, most of the time, I will do a halter just to as a baseline reference, as well as to convince the patient, as well as to whoever the person is referring. We can do a halter. It will be helpful so many ways. But I will not do all the blood investigations, echo, and all those things. I will not do. I will basically do halter if it is normal, means maybe bradycardia may be there. If otherwise normal, there are no significant very long pauses or something like that, we don't have to do anything. Anyway, patient is asymptomatic, so we are not going to do anything for this patient. Just a reassurance and baseline reference, right? Halter may be the only investigation, if at all, I will do. Because sometimes for medical checkup, there will be problems. They need some reassurance, right? For that purpose, otherwise, we don't have to do any investigation. If young patient comes with some bradycardia and is a trained athlete or physically like physical manual worker, we don't have to do these things, right? Right. Okay, so I got few questions in the chat box as well. Okay, so what are the questions? Audio not clear. I think now it is clear, right? There's one question from somebody asking whether sinus node dysfunction and six sinus syndrome is same or not. Anybody? Is it same or not?
Not the same.
Then what is the difference? If sinus node dysfunction could be symptomatic for asymptomatic, right? Sometimes sinus node dysfunction is there. These people are not symptomatic. There may be bradycardia, but patient is not symptomatic, right? So in that case, we don't call it as six sinus syndrome. If patient is symptomatic due to sinus node dysfunction, then we call it as six sinus syndrome, right? Because all the sinus node dysfunctions are not symptomatic. Sometimes there may be a mild chronotropic incompetence, but that is, if patient is not symptomatic due to that, that is okay, right? We can't call it as six sinus syndrome. So that is the difference, right? In this situation, we put it as sinus node dysfunction. Don't put it as six sinus syndrome, right? You see some bradycardia, otherwise healthy, no problem. You might say sinus node dysfunction is there, or is sinus node dysfunction, but asymptomatic. If it is symptomatic due to sinus node dysfunction, we say it is as six sinus syndrome, right? Okay, then the question. Yeah, that's all. Any other questions? Or shall we stop here? It is 1.5 hours almost.
I think number 23 has put up his or her hand.
Number 23. Yes. Dr. Dayara. What is the whoever the person raised the hand can ask the question or what? Or is incidentally or accidentally?
Accidentally, I think. Yes,
Maybe, no?
Yes.
Anybody has any questions, you can always ask, no problem. If you don't have any other questions, we can wind up the session. Thank you very much for everybody for joining the session, as well as Dr. Gurupuram for sharing and moderating the session. And I think Dr. Susita will do the practical aspect of pepper pacemaker in next lecture. At At the same time, if you have any problems with bradycardia, I think you can get my number or you can contact me and you can ask anything, right? No problem.
Thank you very much, sir.
Thank you, sir.
Okay.
Thank you everyone. for
Thank you very
joining, and
much,
thank
sir.
you, Janaka, for coming and giving this lecture. Thank you very much.
Right. Okay.